Welcome to the Counterweight. Happy Monday, and here are the top 3 things that we are thinking about in digital health this week, plus one. First, we're going to talk about the path forward for value-based care. We're going to spend a little bit of time discussing the role of private equity in healthcare. And then we have an upcoming session that's going to be dropped at the end of this week with Kelly Crockett. She is the VP of Strategic Impact with LaunchCode. We'll give a little bit of a preview of that particular session. It is going to be phenomenal. Definitely stay tuned and check that out when it drops. And then I've got some parting thoughts on HIMSS. That's my top 3 plus one. So let's dive right in. Value-based care. Is value-based care dead? I think not. However, it seems like there has been a preponderance of posts, talking heads, if you will, that have been claiming that value-based care either is on its way out, or that it has not lived up to expectations, or that it is not the best model to deliver the right outcomes. And I got to tell you, I'm a little surprised. I'm a little surprised by the pushback. To me, it felt like that this was a train that had unstoppable momentum, and probably for the right reasons. So let's take a moment. Let's talk about some facts, some things that we know, and then perhaps we'll spend a little bit of time talking about where we think it'll go. So first and foremost, there is an expectation, a goal that CMS has set, which is by the end of 2030, 100% of all Medicare beneficiaries and Medicaid beneficiaries would be enrolled in a value-based arrangement, 100%. So we're in 2025. We've got 5 more years to go. Feels like there is actually quite a bit of momentum. Just a couple of stats, if you will. It is already estimated that nearly 50% of all healthcare payments occur in some type of value-based arrangement. What's said in the way, it means that the other 50% is still in a traditional fee-for-service, if you will. Now, Medicare Advantage has the highest percentage of individuals that are covered by some type of value-based care, which is 64% of their payments. So 64% of the payments that go out to providers in a Medicare Advantage plan are in some type of value-based care arrangement. Just as a reminder, Medicare Advantage covers roughly 50% and growing of the Medicare population. That's approximately 30 million individuals that are participating in some form or fashion of Medicare Advantage, and 64% of those payments today are tied to a value-based care model that providers are being incented to participate in. Now, on the commercial side, because really we know that commercial insurance follows the path that Medicare and Medicaid sets out in terms of reimbursement, in terms of models, et cetera. Nearly 40% of payments in the commercial area is in some type of value-based arrangement. So we've come a long way. These initiatives really got its start, if you will, coming out of the Affordable Care Act in the late 2010s, if you will, when that legislation was passed that enabled CMS to create an innovation center. You know it as CMMI. It began to create some of the first models around accountable care organizations. We've had many iterations since then. Some of the newest models is a model called ACO REACH, REACH, in addition to the Medicare Shared Savings Program, which is still going strong. And we've seen a proliferation of other type of value-based arrangements between bundled payments, between other ways to share risk, if you will. So I still am surprised every time I see someone post that value-based care is on its way out. If anything, it feels like the momentum is surging ahead. In fact, if you look at the 2023 performance, that's the most latest results that we have, of the Medicare Shared Savings Program and the ACO REACH program, actively, they saved nearly $7 billion. There's roughly about 500 Medicare Shared Saving ACOs that are operating today. Across that 500, they collectively saved about $5 billion. $3 billion went back to the ACOs themselves. $2 billion was the savings for CMS. And then on the ACO REACH side, which is a more intensive model, allows providers to take a higher degree of risk, and also offers more flexibility in terms of the type of arrangements that providers can enter into. There's only 132 of these ACOs designated as an ACO reach, if you will, and they achieved $1.6 billion of savings. Probably what's also noteworthy is that 32 of the 132 ACO reach organizations achieved 100% total quality score in their ACO performance. So I think the observation is these value-based arrangements are humming along. We're increasingly seeing adoption in government-sponsored plans. We're continuing to see adoption in commercial insurance. We are seeing savings come out as a result. If anything, it's not that value-based care is going away. It's probably more so that the models themselves are starting to consolidate into some more common-oriented models that people would participate in. So a lot remains to be seen. We're 5 years away from the CMS deadline or goal of 100% of all Medicare, Medicaid beneficiaries participating in some type of value-based care arrangement. I would also say, once again, this is not a political podcast, but we do look at the impact of politics on policy within healthcare. And I think it is pretty easy to say that this administration is going to move towards more activity happening in the private markets, and they're going to look to create more programs that tie outcomes to the payments. So if anything, you would expect that this administration would double down or progress forward the programs that are designated as value-based care in some form or fashion. So a lot remains to be seen. I certainly don't think value-based care is dead. In fact, if anything, I think we are on the upswing, and we're going to see a lot more innovation across the health system, especially in terms of different type of models, different type of risk-taking, different type of engagements, et cetera, that is focused on how do we make people healthier for a longer period of time and be rewarded for that in terms of how then we're paid for the care that is being delivered. Now, one of the things that's interesting, and this will be a segue into talking about the role of private equity in healthcare. I want to give a shout out to Rick Renard. He posted at the end of last week a recent primary care scorecard published from Millbank. I'll drop the link to that article in the comments. And some of the observations that were coming out of that particular study is that, one, we are continuing to see a decline in participation in primary care. I think we all intrinsically know that, but the data continues to bear that out as a reality. But a couple of things that really jumped out of the report that are concerning. One, we are continuing to see a downward trend of spending across all payers, whether it's government or commercial, in terms of reimbursement for primary care services. In addition, the spread between what a primary care person is, a doctor, provider is reimbursed is roughly 5 times less than a similar specialist operating in more of a procedure heavy segment of care. So for example, an average reimbursement for a primary care provider is approximately $290. For gastroenterologist, the average reimbursement is just above $1,000. So 5 times more. You will. Doesn't take a rocket science to see why more people who go into healthcare would continue to skew towards these specialties. Now, the tie-in back to the value-based care discussion we were just having is, out of all of the ACO performances, the ones that did the best, the ones that were at the top in terms of total quality, in terms of shared savings, et cetera, were the physician or primary care-led ACOs. So we know that primary care is the backbone. We know that good primary care delivers great outcomes. And we know from the data that when organizations put together and operate in a value-based care way, that having a strong contingent, if not leadership role by primary care, is a hallmark of success. Then why are we not seeing that particular segment of healthcare providers be more rewarded in terms of how they're financially compensated? I've got lots of thoughts on this. We'll save it for another day. I think there is a radical way that we should think about reinventing primary care, but that is the segue into the role of private equity into healthcare because you probably have seen in the news that private equity is buying a crap load of primary care practices, among other practices. They're buying a whole bunch of stuff. So first and foremost, if you're not familiar with private equity or venture capital, you most likely, if you're in the digital health space, have mostly heard the term venture backed or venture capital or VC, because typically that is what we hear when we talk about digital health companies. These are the entities that are typically investing in early to mid stage digital health or technology companies that this investment is helping them grow and then reach some type of exit or return that brings financial returns back to the VCs that are investing in that respective organization. Now, how is venture capital and private equity connected? Well, first of all, they both invest, they both provide financial capital into organizations to help them grow. The difference is that VC funding is typically focused on growth. It's typically in early to mid-stage companies, and they're helping companies get to a certain stage that they can then take an exit, whether it's an IPO or an acquisition, et cetera. Private equity, on the other hand, is they are less focused on the top line growth, although that is important, and they are more so focused on investing in companies that they can streamline, they can make more efficient, that they can improve both the expense side as well as the revenue side. They have an investment time horizon that typically runs somewhere between 5 to 7 years. And then what that means is that when they reach the end of their investment horizon, they are looking to transact that organization. They're looking to transact that investment that they've participated in. And therefore, they will be making decisions in terms of how that business is run to best position them for that type of transaction. This is neither a good nor a bad thing. It is just simply a reality of what happens when private equity invests in your business. So let's talk a little bit about what we're seeing from private equity. So first and foremost, in 2024, this is an article, or rather a report, that came from Bain Capital. Shout out Blake Madden, highlighted this in his weekly newsletter, Hospitality. You can go check out that newsletter, or you can go pull down the full Bain report. But one of the key data points that came out of that is that in 2024, private equity invested $74 billion in the United States in some type of healthcare type related investment. Now, this is compared to a report from Rock Health that indicated that there was $10 billion VC funds flowing into digital health companies. Now, it's not an apples to apples. The private equity firms are investing in a broad swath of healthcare properties. This could be technology companies. This could be provider practices. This could be hospitals. This could be pharma, et cetera, et cetera. That being said, though, it should be no big surprise that the volume, the dollar size, the amount of money that's coming from private equity is dwarfing these other funds that are coming in. And that will have a ramification on what is actually happening or how our healthcare system is working. Now, a couple of other data facts that we've seen in the last decade, we've seen a 500% increase in the number of practices, both primary care and specialty, that are owned by PE firms. In addition, we've seen continued inclination to invest in large health systems. You may recall in 2006, HCA was one of the largest private investments. They took it private, held it. Now HCA has gone back public, and you can go look at their annual reports. But there are some notable large health systems, LifePoint, Ardent, among others, that are privately held, for-profit health systems managed by or invested in by private equity firms. It is said, or at least some of the stats that I found over the weekend, is that nearly 8% of all private, nonprofit hospitals have an ownership from a private equity firm. In the for-profit space, that's 4 times higher. Nearly 22% of all for-profit hospitals are owned or invested in by a private equity firm. So you may be asking, well, what does that really mean? They're providing capital. They're enabling these health systems, these practices to take money, to perhaps expand, to acquire other services, et cetera. Well, those are true statements. And there is a positive to private equity investment. This is not saying that private equity is either good or bad, but there are ramifications that come from that. And I posted on this last week on LinkedIn, but I'll call attention again. There were two reports that dropped One came from Health and Human Services, and the other came from a bipartisan committee in the Senate looking at the impact of private equity in healthcare. And a couple of things that they found, these are fairly obvious statements, but they were validated by over a year's worth of research and analysis that both of these reports independently did in terms of the impact of private equity. What they found is that where there was a proliferation of PE investment in healthcare footprints, providers or hospital systems, et cetera, that it limited competition, which means that it actually drove up prices for respective services, but you saw a decrease in quality of care. There was lower job satisfaction on the behalf of providers because what they actually started to see as they transitioned from non-PE investment to being PE backed, if you will, that the role they played, the things they were being asked to do was sometimes in conflict with how they thought about themselves as a care provider. And overall, it wasn't providing a net positive in terms of the healthcare experience or outcomes for patients. So a couple of the recommendations that were made: increased transparency. This seems obvious. I didn't realize this, but you don't have to expose what your ownership structure is. There was a great story in the podcast that I listened to about this respective article from Health Affairs. Great podcast, by the way. It's called This Week in Health. You should check it out. But the individual talked about going to her dermatology practice and asking, hey, do you know who owns you? And the dermatologist was like, I have no idea who owns me. And then as they started to dig in, it was very difficult to actually find out who owned that practice, because right now rules and regulations are set up in such a way that it's actually fairly easy to obscure ownership of a particular entity if you're investing from private equity. The other thing that was recommended is lower the threshold for FTC reporting. What that really means is today there is a certain dollar threshold. I think it's somewhere around 250 million. It may be actually higher. That seems like a lot of money, but what they were recommending is that number should come down, and it would catch more of these PE transactions that when they were occurring or they're going through the process, they would have to notify the FTC. So that would increase transparency, if you will. And then lastly, one of the common tactics that's being done is when these PE firms invest in providers or health systems, et cetera, they're putting a series of non-competes that prevents the provider, the nurse, whatever, from leaving that organization and going and providing care at another organization. And so they come out pretty strongly and said, we should ban these non-competes. There's been a lot written about this. I'm personally not a fan of non-competes. I actually think it does not foster innovation or competitiveness for a particular company. It has the opposite effect, but certainly was one of the recommendations from these organizations. So if you are looking to join a digital health company that has a PE investment, if you are a founder considering to take PE investment dollars, once again, this is neither a good nor a bad thing. These are simply things that you should be aware of. A PE firm investment comes with a different set of expectations, and those expectations are going to be, we're not just focused on growth, we're focused on managing the expense side. We have a time horizon to exit this for a profit for our respective firm. And as we get closer to that exit period, we will be making decisions in terms of how the business is running to best position it for that exit. So eyes wide open, go into it knowing what you should know, and then make a decision accordingly. All right, last of the three things, I want to give a shout out. We're going to drop an episode this Friday with Kelly Crockett. She is the VP of Strategic Impact at LaunchCode. I don't want to spoil the conversation, but I just got to say this was a phenomenal discussion. LaunchCode is a wonderful organization that I am just now learning about, that invests or provides resources to people who are looking to make a transition in their career and get closer to being in technical roles. That may mean that you're learning how to code. You may be learning data analytics skills, et cetera. I just will make a plug. You're going to hear more about this when we drop the episode on Friday. But this is a great resource if you are a digital health founder to go find both talented and experienced, life experienced people that can come into your organization and have a meaningful impact. Go check out launchcode.org. Get ready to listen to the full episode on Friday. Kelly is a phenomenal person. She's got a great story. LaunchCode is doing amazing things. It will be well worth your time. And here's my plus one. HIMSS is happening this week. At the same time that we're coming to the end of Mardi Gras, so Tuesday's Fat Tuesday, Wednesday is Ash Wednesday. Celebrate accordingly. But HIMSS is being held in Las Vegas. It is the granddaddy of all digital healthcare shows. I am not going. I've spent a lot of time at HIMSS. Our founder and CEO at Cerner Corporation, Neil Patterson, used to say, and I don't think he said this fondly, that HIMSS was a boat show. And really what he was saying is he didn't get a lot of value out of it. For all of my colleagues who are traveling to HIMSS, I just simply wish you the best. It is hectic. It is crazy. Hydrate, have some comfortable shoes, have a plan of what you want to go see. And most of all, don't get distracted by the shiny lights of Las Vegas and come home safely. This is the counterweight for the top 3 things plus one that we're thinking about this week. We're thinking about the role of value-based care, where it's going into the future, the role and investment of private equity into healthcare, Kelly Crockett and Launch Code. That session's coming out later this week. And then a shout out to everyone who has traveled and is currently in Vegas for HIMSS. God bless you. Have a great time. Have a great week. Thank you, everyone.